So, first bill we will have on the agenda is House File 4200. Representative Feist is here, so I will move that House File 4200 be re-referred to the Committee on Labor and Industry, Finance, and Policy. So, Representative Feist, to your bill.
Great. Thank you so much, Madam Chair, and thank you, committee. As a preliminary point, this bill is not the same bill as the Keeping Nurses at the Bedside Act. So if all of you are very excited to talk about complicated staffing committees, we're not going to do that today. House File 4200 is the Healthcare Employee Anti-Retaliation and Labor Act, or the HEAL Act. The Baker Hospital Review recently published an article finding that Minnesota was number 3 in the nation for the search term nurse burnout. In a survey of 2,403 nurses who left the bedside position in the previous year, the most cited reasons for their departure were stress and burnout at 75%, and chronic understaffing at 71%. Nurses indicated that the number one condition needed to return to the bedside was improved staffing. The burnout is similar amongst other care professionals working in hospital and long-term care settings. This bill seeks to address the following trends in how Minnesota cares for patients in hospitals and long-term care settings. First, patient safety in Minnesota continues to decline as staffing levels decline. The MDH's 2022 Adverse Health, actually I think I meant 2023, Adverse Health Events Report cited 572 preventable events, including falls, medication errors, bed sores, wrong site surgery, and the misuse and malfunction of a medical device. Bed sores made up the vast majority of reported events. A recent study involving nearly 54,000 patients found that staffing levels correlated with bed sores, and numerous studies have connected unsafe staffing with adverse events more broadly. The second trend is that when staff speak up because they believe they cannot safely care for a new patient, they experience retaliation. And I would encourage the committee members to look at the letters that were submitted today. This retaliation includes being sent home, even when understaffed, not receiving vacation requests, verbal abuse, losing shifts in scheduling, and being put on challenging schedule with the least preferred shifts. It does not make sense that hospitals send staff home when they have just cited deep concerns over unsafe staffing levels that they believe place patients at risk. To combat these trends, this bill provides labor protections for direct healthcare workers in acute care settings when advocating for safe patient care. And I would just like to emphasize that they already do advocate for safe patient care on a daily basis. This bill simply provides labor protections for when they do so. Specifically, it prohibits retaliation against patient care staff when they reasonably believe that accepting a patient assignment would create unnecessary danger to a patient's life, health, or safety. This bill explicitly states that the language does not pertain when patients are in need of urgent medical care. To anticipate some questions that you might have, does this mean that patients don't receive care? No. This puts the responsibility on management to find patient care solutions instead of continuing to unreasonably burden the direct healthcare workers, placing patients in danger. Hospitals have the capability to do this if they choose. For example, hospitals regularly schedule elective surgeries that they don't have the staff to care for after they're released from surgery. We also know that hospitals use benchmarking in order to staff at lower levels in order to maximize margins. Another question that you might have is, what if hospitals don't have enough staff to meet the need? MDH reports that there are more nurses in Minnesota than ever before, yet they are leaving hospital jobs because of working conditions. We hear the same across all direct healthcare job categories. If hospital administrators do not create safe conditions for workers and patients, we will only see the number of direct healthcare workers fleeing the bedside increase, and this bill provides a solution. Last question that you might have, I'd like to proactively address, is does this mean that workers can decline patients that they don't want to serve out of bias or a desire to avoid difficult patients? And the answer is no. This bill very explicitly prohibits discrimination through incorporation of the Minnesota Human Rights Act and does not prohibit discipline based on performance issues. So if somebody is not doing a good job with their patients, or if they're consistently refusing to work hard, or if they don't like certain types of patients, like that's grounds for discipline, and that is absolutely okay. way. Rather, this just protects workers who are advocating for safe patient care. And I will point out that under the Nurse Practice Act, nurses already have a professional ethical obligation to do so. Nurses keep coming to the legislature, and they're saying that this is a crisis. And the legislature has refused to listen for decades. The status quo is driving nurses from the bedside, and it is placing patients at risk. There is broader healthcare workforce shortage, and we need the dedicated professionals who choose healthcare careers to remain in these roles. And as just a final comment, I just want to emphasize that this bill is about empowering workers who advocate for their patients. And it's about shifting the burden to provide adequate care from those without power, the immediate healthcare workers at the bedside, to those with the most power to do so, the hospital administrators. And lastly, I just want to say that, as I think all of you know, I'm very collaborative and open to continuing to work with people who might have input on this bill to make sure that it is the best it can be. Thank you.
All right, well, thank you for that introduction, Representative Feist. And before we go to testifiers, I do just want to remind everyone in the room, I should really say this before every hearing, but we don't allow any sort of clapping or outbursts or booing or anything like that. So just to ask those in the audience, although these issues can become very emotional and so on, just to ask everyone to maintain decorum. So thank you. The first testifier I have on the list is John Welsh. And then next will be Elena Hain. So please, Elena Hain, so please be ready to come up after. Welcome to the committee.
Thank you, Chair Liebing, and committee members for this opportunity. My name is John Welsh, and I'm a registered nurse on the cardiac floor at Unity Hospital in Fridley. House File 4200, or the Healthcare Employee Anti-Retaliation Act, is a priority for MNA members because the executives running our hospitals are creating unsafe staffing conditions that result in real harm to patients. And when nurses speak up about their assignments, too often they face retaliation and discipline. When nurses have to accept an unsafe assignment, their jobs and licenses are on the line. We know adverse events continue to rise every year. MDH's reports confirm it. The incidence of hospital-acquired pressure ulcers, or the large, deep bed sores, have doubled in the last 10 years. After Keeping Nurses at the Bedside Act was defeated last year by Mayo Clinic's threats, hospitals took advantage by making staffing even worse. At my hospital, Allina Health severely cut back our nursing assistants and nurses in October. I'm working with more patients and have fewer nursing assistants to help. The care we provide is suffering. In the 3 months since we reduced staffing, my small hospital has had 3 reportable hospital-acquired pressure ulcers. In the previous 6 months, it was 0. Nurses who speak up about it, though, become a target. A nurse at Cambridge Medical Center was harassed by her manager after she filed a concern for safe staffing form regarding staffing on the night shift. A group of nurses on the highly skilled step-down unit at United Hospital were all sent home and subjected to a disciplinary process after they sought additional help at the start of a shift. Hospital leaders were more willing to send nurses home and possibly harm patients than work with them to develop a safe plan of care. Under the Nurse Practice Act, a nurse has a duty not to accept an assignment they cannot safely provide care for. But under current law, a hospital can discipline a nurse for doing just that. This puts us in situations where we're choosing between keeping our jobs and protecting our licenses. As hospitals continue to make profit-driven decisions that result in unsafe staffing, patients need nurse advocacy more than ever. The HEAL Act will help prevent nurses and other healthcare workers from retaliation for responding to an unsafe assignment and allow us to provide the safe and dignified care our patients deserve. Thank you.
Thank you. Elena Hain, and then Adam Carlin. Welcome to the committee. Sorry if I'm butchering your name.
That's okay. Good morning, Chair Liebling and committee members. Thank you for the opportunity to testify today. My name is Elena Hain, and I am a registered nurse and the interim executive director at the Minnesota Nurses Association. More importantly, I am one of the thousands of registered nurses across Minnesota who gave up bedside nursing because of the constant pressures of unsafe staffing and the moral injury associated with hospitals prioritizing their bottom lines over patient care. Hospital bedside staff are in crisis. They're here today pleading for the real solutions that allow them to have the safety and security they need to do their jobs. Dozens of objective studies prove that appropriate staffing levels in hospitals lead to better patient outcomes. And as the number of patients per care team increases, so do higher rates of negative outcomes, such as pneumonia, shock, cardiac arrest, or urinary tract infections. Yet, shift after shift, as workers appeal to hospital leaders for help with seriously unsafe staffing, they are often met with indifference at best. Instead of listening to nurses who are saying that in their professional opinions that they cannot safely care for an additional patient, hospitals are consistently telling nurses to make do. But making do isn't only causing further harm to your mother, father, grandparent, or even your child. In your materials today, you will see a story about how one Allina hospital chose to put mats on the ground and increase camera surveillance when a nurse and nursing supervisor expressed their concerns about staffing levels. Despite appropriately escalating the concern up the chain of command, the management team at this hospital determined that a few extra mats on the ground was less expensive than attempting to find another nurse to care for this patient. Cameras and mats weren't able to help that patient when they fell on the ground. And neither was the nurse whose patient assignment was already too much to handle. What if it was your loved one who fell? Are cameras and mats really acceptable solution for people in their most vulnerable state in these hospitals? Recently, one of Minnesota's largest hospital systems, Allina Health, went through a process called benchmarking. This is a process where a private consultant chooses a subset of hospitals across the United States and shares the average staffing levels and outcomes for each of the facilities. Upon receiving this information, Allina decided that they didn't need to provide staffing levels at the best of the hospitals that they're being compared to. They didn't even decide that they needed to provide staffing levels of those hospitals that are ranked at 75% or even 50%. Instead, Allina Health chose to benchmark at 40% the level of staff. This is why, despite claims of a nursing shortage, Allina facilities are now closing units and laying off nurses, if you can imagine that. And to make matters even worse, this all on top of a recent report by the Minnesota Department of Health shows that almost 13% increase in preventable patient safety events that result in death or permanent harm or severe temporary harm. As a nurse, this is not acceptable to me, and it isn't acceptable to the 22,000 nurses of the Minnesota Nurses Association. We are asking for your help. You have an opportunity with this bill to save patient lives and keep nurses at the bedside. We are here today asking for your help. Please do not leave us behind, and please vote yes for moving this bill today. Thank you.
Okay, thank you for your testimony. Adam Carlin and then Melissa Fraudette. Welcome to the committee.
Madam Chair, my name is Adam Carlin. I'm the Chief Nursing Officer at M Health Fairview Southdale Hospital. I've been a registered nurse for 15 years, including 9 years in varying leadership roles. I'm proud to be a nurse leader, and I'm grateful for the opportunity to represent my colleagues today. To put it simply, I have grave concerns with Section 5 of the bill, which authorizes hospital nurses to unilaterally refuse, with impunity, to accept a patient. This provision has the potential to confine some of our most vulnerable patients, including those experiencing mental health crises, to our extremely busy emergency departments. This bill creates significant opportunity for individual bias to determine who receives care in our hospital, bias to which our nursing profession is not immune. On a personal level, as a member of the LGBTQ+ community, I am deeply concerned how this bias refusal could impact my care. High-quality care requires a team. Teams that work around the clock to create safe working environments for our patients and their colleagues. Teams that work to determine the best location for patients under our care. This includes elective procedures, and to be clear, elective procedures would include things such as cancer surgery, open heart surgery, anything scheduled in advance. This means doctors, advanced practice nurses, therapists, and other members of the team working together in a delicate balance to properly care for patients. The legal sanction of patient refusal for one role within the broader healthcare team disrupts this delicate balance. It recklessly endangers patients and would significantly limit our ability to ensure reliable access to hospital care for all patients. Of concern, the authors of this bill have used the term retaliation to describe professional nursing accountability with respect to patient refusal. Minnesota already has strong whistleblower legislation with important protections for individuals who, in good faith, report situations in which the quality of healthcare services is in question. This law protects nurses that speak up. There is no substantive proof that there is widespread nurses who are raising legitimate patient concerns who are facing retribution from their employers. In fact, at Fairview, our safety always culture requires staff who have questions or concerns to speak up, to practice a questioning attitude, and to communicate clearly when there are issues. Authors of this bill have mistakenly confused retaliation for accountability. And in the case of Section 5, which gives nurses unilateral authority to refuse patients, this lack of accountability will create serious problems. It's important to consider the impact of this proposed provision will have on our underserved, marginalized, and vulnerable patients, patients that we care for in our hospitals every day. It is not a bridge too far to see this provision to be used to the extreme, giving people with conscious or unconscious bias the ability to pick or choose their patients, or further, clearing the way for mandatory staffing ratios through sanctioned patient refusal. We have existing whistleblower laws. We have existing internal processes and protocols to support safe care environments in our hospitals.
I have to ask you to wrap up, please.
We will continue to oppose this provision. Thank you.
Thank you. Melissa Fraudette and then David Klanaugh. Welcome to the committee.
Good morning, and thank you, Madam Chair, community members. My name is Melissa Fredette, and I serve as the Executive Director and System Chief Nursing Officer for CentraCare. I've been a registered nurse for over 23 years and in leadership for 10. I would like to talk about how hospitals staff their units and how difficult it would be to operationalize the situation when and if a nurse refused a patient assignment. We take many things into account when we make patient assignments. Some of these factors include a nurse's skill set, expertise, and years of experience. This then is matched with a patient's acuity and complexity, along with their physical, spiritual, and psychosocial needs. Patient assignments may be altered based on patient condition and/or unit changes. All hospitals have staffing plans which are publicly reported, with quarterly information about actual staffing levels and number of patients served. Nursing units are staffed with core staffing patterns based on historical patient volumes and acuity. We know hospitals can become busier than normal. During periods of high census on nursing units, we can use float pool nurses, or staff may assist from other units where patient census may be lower than anticipated. In addition, nurses can be alerted for additional assistance when needed, when nurses call in sick on a relatively short notice. There are times when we can anticipate higher volumes and can plan accordingly. For instance, our teams can huddle to look ahead at surgical volumes and staff above our core nurses' staffing patterns to account for the additional volume or for higher acuity or for patients with longer length of stays. This is different than a nurse refusing a patient assignment. Under this scenario, the nurse is already at work and chooses not to care for a patient. Charge nurses may be able to change that nurse's assignment, but that's not always possible based on their expertise or the expertise of other available nurses. Sometimes it's possible to bring in an additional nurse, but it may take time for that nurse to arrive, up to 60 minutes in some circumstances, and that leaves the patient without a nurse, which could lead to unsafe conditions for that patient. Hospitals have procedures in place to accommodate staffing requests. This is an issue which should not be put into statute. Resolution should be achieved through collaboration on nursing units. Thank you for your consideration of my comments, and I'm happy to answer any questions you may have.
Thank you for your testimony. David Klanaw and then Brad Lato. Welcome to the committee.
Good morning, Madam Chair and committee members. I am David Klana, and I serve as the Volunteer Services Coordinator at the Minnesota Sex Offender Program in Moose Lake. Thank you for this morning's opportunity to testify in support of House File 4200 as a Minnesota Association of Professional Employees member. In my work, I support volunteers in providing spiritual and support group services, working directly with many colleagues and about 150 clients through a wide range of modalities in a therapeutic setting. Working with these clients is quite challenging, especially with high turnover and chronic understaffing. That said, I really enjoy the work and wish I did not need to be here today as tasks pile up and colleagues feel extra stress. I wish I was at my workplace confident in a consistently safe environment and a culture receptive to staff feedback concerning staffing and safety issues. Sadly, that has not been my daily experience, and I am not alone. I am here to speak for myself and colleagues from various bargaining units who frequently approach me about feeling caught between a rock and a hard place, having to do tasks when they do not feel safe, yet feeling if they refuse, they will be, quote, disciplined. This involves direct safety situations, but also being frequently forced to work double shifts, being reassigned repeatedly during shifts, and feeling discouraged from participating in union work. Colleagues have also shared extensively about the high turnover rate. They note that people leave when they feel they are given impossible tasks, inadequately supported, unfairly disciplined, or observe questionable discipline targeted toward people who speak up about safety issues. These factors make it more difficult to recruit or retain enough capable colleagues so we can deliver the high-quality programming needed to rehabilitate clients in an environment safe for everyone. Without sufficient capable and experienced staff, clients who may not be ready could be mistakenly released into the community. Also, clients with potential to do their work and return home can be delayed in their journeys with extra taxpayer cost. This bill would allow staff to request modified assignments without retaliation. It would provide therapeutic, rehabilitative staff in state facilities overdue protections to confidently share both staff and patient safety concerns with their supervisors. After clients assaulted 5 colleagues at MSOP Moose Lake last year, it is clear the status quo does not work. Please support House File 4200. Please give patient care staff stronger, more secure voices in our workplaces. Thank you.
Thank you for your testimony. Brad Lato. Welcome to the committee.
Thank you, Madam Chair. Good morning, and committee members. My name is Brad Leto, and I'm the Secretary-Treasurer of the Minnesota AFL-CIO, the collective voice of Minnesota's unions. And again, thank you for the opportunity to testify today. Obviously, I'm here to support House File 4200, the Healthcare Employee Anti-Retaliation and Labor Act, the HEAL Act, and I thank Representative Weiss for authoring this bill. I hear from the hospitals that they do not retaliate. You've also heard that they do. House File 4200 protects workers from retaliation for refusing to take on too many patients. As an additional assignment may create unnecessary danger to patients' health, safety, and life. Let's say it's you that have one of your spouse, your son, your daughter, your whoever, and all of a sudden there's 6 or 7 patients, and you're the next one, and then the healthcare professionals are supposed to give you the same amount of time. I think that we know that that's unlikely to happen. The bill, the bill also establishes a process before staff decline care, but if it push comes to shove, they can decline a new patient. As Representative Feist mentioned, retaliation takes many forms. Unfair scheduling, being sent home without pay, hard to believe when we have a shortage of nurses and other healthcare professionals, and being denied time off. It's obvious we do not have enough patient staff in this state. We have an even more acute shortage of BIPOC, Black, Indigenous, and people of color patient care staff. Progress is being made as more BIPOC patient care staff are entering the field. Do we really want to jeopardize that process? Do we want to continue to overload the current RNs and other nurse assistants, LPNs, CNAs, and other patient staff, and have even more healthcare professionals leave their jobs? Everyone has a breaking point with their jobs. The Minnesota AFL-CIO and the Minnesota Nurses Association, AFSCME, Councils 5 and 65, SEIU Healthcare Minnesota and Iowa, Food and Commercial Workers, UFCW Local 1189, Steel Workers, USW, and MAPE, as you've heard, all support this bill. These unions believe that, again, everyone has a breaking point in their jobs. House File 4200 tries to alleviate that breaking point. The bill tries in one small way to heal the patient care system with protections for care workers on the front lines of the fight to improve our healthcare system for workers, patients, and families. The Minnesota AFL-CIO asks you to support 4200. Thank you for your time.
All right, thank you, Mr. Leto, appreciate it. Okay, well, that is the end of the list of scheduled testifiers, so I think we can move to member discussion. So Representative Quam.
Thank you, Madam Chair. And earlier on, it was said that we haven't been listening and taking care of, and frankly, the majority of information we heard on the previous session was dominated by an entity that represents less than 18% of the nurses. And actually, it might be lower now because I know several hospitals have the nurses voted to not have them represent. So I wish we had a more balance. But we just heard, you're the sixth one, and because of staffing, they're not going to give you as much time. So this bill's solution is that then you're turned away because the staff will say, nope, I'm not going to help because we're understaffed. The complaints about understaffing, the body's rejected participating in a nurses' compact, which would allow nurses from multiple states to be able to fill out openings. And so I think that should be a bit of a priority of actually trying to build the staffing to care for the patients. And, there was a disparaging thing about a world-renowned entity and threats and this and that. Well, frankly, if we want to make decisions appropriately, we should have a study that shows over the last 10 years at hospital locations the type of issues that have been incidentally picked up anecdotally here. And let's see the patterns and comparison between the different systems, because there may be things that some entities are doing as a medical team, which is more effective than this approach that we're battling over. So, frankly, we should be addressing the underlying causes, such as the low reimbursement rate from government programs, the lack of staffing, and I don't see this bill addressing that. Thank you, Madam Chair.
Thank you. Representative Bonner.
Thank you. I was going to ask some questions, but I'm just going to save us some time and talk about this. Everyone here knows my mom is a nurse, 43 years at the county, one of the most difficult facilities in the state. And we've heard these accusations that nurses are going to willy-nilly refuse an assignment. That is baloney. Let's call it what it is. every nurse goes into nursing to do their absolute best, to deliver the best patient care every single shift, day after day, hour after hour, minute after minute. That is what they do. There are nurses that will constantly work to make do if they are short-staffed. So that is nonsense. If they are short-staffed, nurses will step up and they will pitch in and they will help each other out. That's what they do. They do it every day. What we're talking about here is when a nurse feels that there is a serious risk to a patient's health and safety due to on-staff staffing, that they have a right to stand up and call it out. That is what we were talking about here today. This assertion that nurses would not hold up to their obligations or to do the right thing is ridiculous. And frankly, it's insulting. And I just have to say, this issue is not a new one. It has been around for decades, and it continues to be a continual problem. And until we find an actual solution, potentially this bill, it's going to continue. So let's just get it done.
Representative Bonner. So we're going to have New Brindley, Schumacher, Baker, Smith, and then we'll go on to the next bill. So Representative New Brindley.
Thank you, Madam Chair. And Representative Feist, I'm wondering, in your opening remarks, you had said that this will not apply to nurses who are denying taking patients on every shift, or if they are the only nurse who refuses to take a patient. You sort of indicated that all these things that it doesn't cover. And I'm wondering if you can just show me in the language where those things are sort of exempted and that is not allowable under this language.
Representative Feist.
Yeah, thank you. I was riffing a bit, but basically what this bill protects is very specific actions that are already protected under whistleblower law and already required for nurses under the Nurse Practice Act. And so at line 4.20, it talks about this is about when a nurse or patient care staff reasonably determines that accepting that additional patient assignment is unsafe for that patient. And that is the only scenario that this covers. So if a hospital has reason to believe that the nurse is not being reasonable, like we're creating an objective legal standard through this bill that doesn't exist currently under law. So if they're not behaving reasonably, if there is reason to believe based on that nurse's pattern of practice that they are acting out of bias or laziness, or every Friday they just happen to not, feel like this patient assignment is safe, they will have the ability to look at the whole picture, of the nurses, and patient care staff's pattern of behavior, and take action as necessary. And this bill is really specifically laid out to cover just that reasonable belief that that patient assignment would be unsafe. And again, that is behavior protected under whistleblower law and the Nurse Practice Act.
Follow-up.
Thank you, Madam Chair. Representative Feist, as I read this, and I think I've read it pretty thoroughly, it looks like the patient care staff member is the sole determiner of what is reasonable. Multiple times the language is used, if the patient care staff reasonably determines. So that is at the sole discretion, and maybe this just needs to be cleaned up a little bit in language, but right now, the way it reads in multiple locations of the bill, it is at the sole discretion of the patient care staff person, and they reasonably determine. And I know you're saying that that's an objective standard, but the way this is written, there could be 5 nurses on a floor, and one of them reasonably determines that it is unsafe, but the other 4 could say, well, I think it's fine, and I'll take the patient. And there is no mechanism to take that into consideration. And in fact, it's clearly laid out in the beginning of the bill, the prohibited actions about retaliation. The only exception to that is subdivision 4. And when you go down to subdivision 4, that just ensures that they can have a labor representative. It does not give any indication of the fact that if 4 other nurses on the floor reasonably determine that it is safe, that this individual who believes it is unsafe is wrong. There's no mechanism, and I'm just saying in plain language, I understand what your intention is, and that may be noble, but that is not what your language does. Your language gives all power to an individual when there may be 5 or 10 other people saying they're just wrong. They're just wrong. Thank you, Madam Chair.
All right, well, thank you, Representative Brindley. And I just want to point out, this is going to the Labor Committee, and the part of the bill that I think you're referencing is actually, I think, under the labor statutes. And so I think some of these issues are the very ones that will be discussed in the Labor Committee, because I don't know that we here deal with this exactly, so, but appreciate your concern.
Reasonableness.
I appreciate your concern. I think that's an issue that is a legal standard that exists already and will be fleshed out. I'm going to go to Representative Schumacher.
Thank you, Madam Chair. I guess my first bit of questions, well, actually, it's an assumption that this applies to state and municipal-run hospitals as well. So my first question would be that on the fiscal note, and if that's been requested and where the status of that might be.
Representative Feist?
It has been requested and not yet received.
Okay. Thank you for that. I'll look forward to that. The only other question I had for today's hearing on this is, Representative Feist, you mentioned in your introduction, and then I didn't hear about it again, but you were talking about long-term care and how this also applies to them. I see on page 3, lines 22 through 24, that they would be included with that, and any facility licensed under the Commissioner of Health. With long-term care specifically, everything is referenced to patients. There's no reference to residents in here. And my question is, if it does apply to long-term care, like it reads like it does, how will this work with the new CMS regulations that we're expecting this summer regarding the 24-hour RN policies? And what other facilities, it looks like those lines are comprehensive, but what other facilities are out there besides the hospitals that we've been hearing about today? Thank you.
Representative Feist?
Yep, thank you for the question. I'm going to answer it, and then if somebody else says I answer it incorrectly, they can step up. And but this only applies to acute care settings, so it is more narrow than that. And I do know that in the drafting that we struggled with, obviously patients and residents would both be covered, and so we could look at trying to reflect that more clearly in the definition section, but that was the intent. But again, it's only acute care settings.
Okay. All right, Representative Backer. Oh, I'm sorry. Let's go to Ms. Clark-Vist for a second.
Madam Chair and members, I just wanted to point out on lines 4.24 and 4.25, it says that subdivision 1 at least does not apply to nursing homes, ICFs, DD, and boarding care homes.
Thank you.
Thank you.
Okay, Representative Backer. Not Baker, sorry.
Yeah, it happens. So thank you. Also, I asked for a roll call vote.
Okay, roll call.
My question here, I can't quite see you, I'm way back here, Representative, but as an EMT personnel, when I look at this bill, this is how I interpret it. And so I'm looking for some insight. As an EMT, I can't refuse care. Doesn't matter. The challenges that we face on a traumatic run or a suicidal or mental health, behavioral health issue, I can't refuse it. Emergency departments can't refuse providing care. But when I look at this bill, that is what I see is that nurses can refuse care. So I can't do it as an EMS. If I would I would be taken through the EMS RAB board and so forth, which had happened to me once. It wasn't a refusal, it was just miscommunication with the family. I've been through the whole process, but the nurses can do this. And that's what concerns me because I volunteer to provide care. So help me with that question, please. And that's the only question I have, Madam Chair. Thank you.
Thank you, Representative Feist.
Yep, thank you. So just to confirm, oops, sorry, I'll go back to my mic, then I won't be able to see you. But just to confirm, we do have specific language about emergency medical situations, so that is a carve-out. But I just want to emphasize again that we are not creating new behavior or a new right. Like, people are already protected under the whistleblower protections for doing what is laid out in this bill. And again, just to emphasize, the Nurse Practice Act actually requires that when nurses feel that a patient assignment is unsafe, they have an obligation to say so. What we're doing is we're providing labor protections for something that patient care staff already do at great risk to their own careers, and in order to stand up for the patient. So we are creating labor protections for something that people already do, but honestly, a lot of people are afraid of retaliation. And again, the goal is to shift the burden for ensuring that hospitals and care facilities are safely staffed from the bedside care professional who have the least power to make macro level changes to the hospital administrators who have that power and authority.
Okay, thank you. And so Representative Nadeau, you raised your hand kind of after I was going to kind of conclude this.
Really fast.
Really fast, go ahead.
Yeah, thank you, Madam Chair. And it was one of the answers that I wasn't going to speak to the bill, but there's a conflict, it seems to me. I was going to ask about line 4.24, where it's not applying to nursing facilities, ICFs, developmental disabilities, licensed boarding homes. And then you had one of your answers said it only applies to acute care hospitals. That's it. Acute settings.
Yeah.
Okay. And then if I look in 5.22, that's where it seems to me that the conflict occurs. And I know that the intent here is to apply to state-operated services, I'm guessing, but it just seems to me that there's a conflict in where this can be applied and where it can't be applied. Can you just quickly answer that for me?
Representative Feist?
Yep, thank you. I don't know that I can quickly answer it for you, but I'm happy to connect with you offline to go over it to make sure that there isn't a conflict. I think the intention at line 4.24 was to make it clear where it did not apply. And so it might be something, I'm a big fan of making implicit things explicit just to make sure that it's not unclear. So I'm happy to connect with nonpartisan staff and to make sure that that is really explicitly clear.
Okay, thank you. Thank you, Representative Nadeau. Representative Smith?
Thank you, Madam Chair. I will be quick. My clarifying question here, there's been a lot of talk about potentials of nurses, not wanting to provide care. And as I listened to some of our testifiers, some of the written testimony here, Ryan Hilmo, who's an RN who has a letter in here, stated specifically that his entire cardiac unit was dismissed for the day without pay when they raised questions about this. Another testifier mentioned, I think it was Mr. Welsh, about being sent home several times. To me, that kind of sounds like a forced refusal of patient care from the management side of things. So my question is maybe just clarifying when these nurses are maybe we don't want to use the loaded term, retaliated against, but are told to go home. We're all concerned with patient care. What happens to the patients in the units when those nurses are sent home those days?
Representative Feist?
Yep, thank you. That's a really good question. I could answer it like in abstractions, but would one of our nurses like to come up and provide an example?
Okay, we're really pressed for time, though.
Sorry.
I mean,
I can say the short answer is that patients don't receive care, and in fact, they receive less care than they even would have. Oh, it looks like we have an expert.
Okay.
We'll be fast.
Okay, welcome. Please state your name again for the record.
John Welsh from M&A. In that instance, the night shift was asked to stay later.
Yeah, all right. Thank you. Thank you very much. All right. With that, Representative Feist, do you have like a 15-second closing?
Sure, 15 seconds. This is a really important labor bill, and I urge members to support it. Thank you.
All right, thank you. So Ms. Niederhofer will take the roll on the bill. So I'm going to renew my motion that House File 4200 be re-referred to the Committee on Labor and Industry, Finance, and Policy.
Chair Liebling.
Aye.
Liebling, aye. Vice Chair Bierman.
Bierman, aye.
Bierman, aye. Leach Schumacher.
Schumacher, no.
Schumacher, no. Representative Acom.
Acom, aye.
Ingham, aye. Representative Thacker.
Backer, no.
Thacker, no. Representative Bonner.
Proudly, aye.
Bonner, aye. Representative Carroll.
Aye.
Carroll, aye. Representative Elkins.
Elkins, aye.
Elkins, aye. Representative Fisher.
Fisher, aye.
Fisher, aye. Representative Hemmingson Jaeger.
Aye.
Hemmingson Jaeger, aye. Representative Herr.
Her, aye.
Herr, aye. Representative Keel.
No.
Keel, no. Representative Murphy.
No.
Murphy, no. Representative Nadeau.
No.
Nadeau, no. Representative New Brindley.
No.
New Brindley, no. Representative Perryman.
No.
Perryman, no. Representative Kwan.
No.
Kwan, no. Representative Ryer.
Ryer, aye.
Ryer, aye. Representative Smith.
Aye.
Smith, aye.
There being,
Yeah.
11 ayes and 8 nays, the motion prevails, and the bill is re-referred to the Committee on Labor. Okay, thank you, Representative Feist.